morning all. Efficacy of ab interno revision for trabeculectomy blab failure. So trabeculectomy is the most commonly performed glaucoma surgery, but with time it gets failed because of subconjunctival and subscleral flap fibrosis. So there are management options to revive failed trabeculectomy blab are like needling. Needling is more useful in case of subconjunctival fibrosis and encapsulated blab, but in case of subscleral flap fibrosis, it is relatively blind procedure. On the other hand, the blab repair via external approach is more surgery because it requires conjunctival dissection and reopening of the scleral flap. So ab interno revision, blab revision, it is less invasive procedure with more controlled and predictable approach. So this is the Grover-Fallman biplanar sclerostomy spatula, no financial interest. So the distal end of Grover-Fallman spatula is 20 mm long and the width is 0.5 mm, and this tip is flat, blunt, and so the side are cutting and the tip is blunt, so it allows the dissection of subscleral and subconjunctival fibrosis, and it has slightly anterior curvature so that it can fit in along the curvature of globe. So the aim of this study was to assess the safety and efficacy of ab interno blab revision. So patients with failed and scarred trabeculectomy blab with patent sclerostomy were included in this study, and in all patients pre-surgical treatment with MMC was done 5 to 7 days prior to surgery. It was an OPD based procedure. Subconjunctival injection of MMC 20 microgram was given in region of failed trabeculectomy blab, and we also started topical steroid drop. So this is the surgical technique. So this is the right eye, and surgeon is sitting temporally, and so I will show a small video. So surgeon is sitting temporally, and this is the scarred blab. So we are making a paracentesis almost 180 degree away from the scarred blab, and then pilocarpine and viscoelastic is injected, and with help of gonioscopy, we are inserting the Grover-Fallman spatula in the sclerostomy. So this is the indirect gonio lens, and in the inferior mirror we can see the spatula going inside the sclerostomy. Once it is inside the sclerostomy, we remove the gonio lens, and then with sweeping movement or side-by-side movement, we are gently dissect the scar tissue. And once it is in the subconjunctival plane, so once it is in the subconjunctival plane, the blue tip of the spatula is visible in the subconjunctival plane. The end point of this procedure is a shallowing of the anterior chamber with formation of the diffuse bleb. So total 23 patients were included in this study, and mostly patients were primary angle closure glaucoma, approximately 50%. Mean age of failed trabeculectomy bleb was 5.35 years, and pre-ab interno intervention was already done in 11 patients, including retrabeculectomy, needling, and external bleb revision. All patients completed 1 year follow-up, but after 1 year, 6 patients lost to follow-up because of COVID pandemic. Intraocular so this is the intraocular pressure. It was pre-surgery. Intraocular pressure was 23.08 mm of mercury, which decreased at 1 month follow-up. It decreased to 15.91, and at 1 year 13.5, and it maintained to 14.6 at 3 years follow-up. And this is the line graph showing change in anti-glaucoma medication. It was 3.72 before ab interno bleb revision. At 1 month follow-up, it was 0.54. At 1 year follow-up, it was 1.3, and 3 years follow-up 1.6. At all visits, a statistically significant difference was in and p-value was less than 0.01. The complications, hyphema was noted in 5 patients, and 4 patients it was spontaneously resolved, and hyphema washout was needed in 1 patient. There was no other serious complication like choroidal detachment, corneal or lens injury, or suprachoroidal hemorrhage. So total success at 1 year follow-up was seen in 82.6% eyes, and out of which complete success where intraocular pressure was maintained without need of anti-glaucoma medication, that was seen in 39.2% patients. Failure was seen in 17.4% of patients. There was no cases of hypotony or failure because of raised intraocular pressure. So here are some pictures of so this is the pre-operative flattened scarred blab, and ab interno blab revision was done. This is post-operative day 1. We can see the diffuse blab, and this is the 3 years follow-up, and we can see the low diffuse filtering blab is maintained, and intraocular pressure is 14 mm of mercury without anti-glaucoma medication. Another patient with 2 previous failed trabeculectomy, superior and superior-temporal failed trabeculectomy blebs, and ab interno blab revision was done. Here we can see the diffuse blab is maintained, formed post-op 1 week, and we can see the fluid in the subscleral flap space, And post-op 3 years, the fluid is still there, and intraocular pressure was 14 mm of mercury without anti-glaucoma medication. To conclude, ab interno bleb revision, we found it a safe, effective, and minimally invasive intervention, as it doesn't require reopening of the conjunctival flap and scleral flap. And this spatula is reusable instrument, and the learning curve is required, but it can be learned by most of anterior segment surgeon. Thank you.
Thank you very much. And I did want to ask you that your results appear to be relatively better than most other studies, actually. This is from the review that you wrote up, actually. Was there something in your technique that you might say that, we did much better and, this is what worked, actually?
Sir, MMC, 5 to 7 days
that
before
was there
surgery.
in the other. In fact, I was coming to that
Yes.
as the next question. That the dosage of MMC that you used was much less than what
20
other
microgram.
people have used. And did that help, or do you think that using a slightly higher dose might have led to even better results, actually?
There may be chances of hypotony. There was no hypotony in our patients, and so MMC was given, and we also started topical steroid eye drops. And in post-op follow-up, we also give the bleb massage, sir.
Okay.
And 5-FU also in some patients if there was corpus growing of the vessel. So,
okay. One of the most important things when you do something, because the time that it took for the trabeculectomy to the time that you did that was very big, isn't it? That these were not post-operative.
Actually, it was the mean, and one patient it was 17 years. So maybe
that's right. So I'm just coming to that. Was there anything that you identified? Because this is very special. It's very important. Was there anything that you could identify that this is a group of patients that's likely to do well, actually?
Sorry, sir?
From all your patients, were you able to identify that there was this group of patients that was likely to do very well, actually?
Yes, sir. In patients with multiple surgeries, in aphakic patients, the bleb revision result was not good. And if it is just trabeculectomy and we are doing the bleb revision, the results was good. But in case of aphakia or multiple surgeries like pars plana vitrectomy in one patient, it was already done. So the result was poor in those cases. More chances of
Did
scarring.
morphology had any effect? You see, there were encapsulated blebs also and the flat blebs also. Was there any difference in the two, the results, the outcome?
Sir, in case of subscleral flap fibrosis, if there is subscleral flap fibrosis, if there is
I'm just asking, there were two
yes,
types. You see, it
yes,
depends, according to literature, it depends on the physical properties of the bleb also.
We can try some needling, because there is.
Secondly, in the original study, as sir said, you used less concentration compared to the original one. They used 4 microgram and used only 2-1. So my question is, there was no complication in that study also. The result was based on the outcome success rate. That was 77 something %, and yours is much better than that. So in spite of using less concentration, you had a better result. I'm not talking about the complication. Even that study didn't show any complication.
Maybe we are better dissecting the scar tissue and all.
All right. Okay, I mean, these are all difficult questions. There are no easy answers to them, but we just wanted you to think about these. Thank you so much.
Thank you, sir.